Alright, so how many of you have done strain before? How many have you done echo before? Echo, you all done my mind already. Strain, has anyone done before?
No.
No, okay. But have you heard of strain before? Yes.
Stress the cardio, stress the heart.
No, strain no need to stress heart. Please, don't need. We don't have to stress heart. But strain is, I think the most usual way people would talk about strain is this one, this bullseye plot. Have you ever seen before? Okay, so this bullseye plot, people will talk about cherry on top and all that. You hear this over and over in certain cardio conferences lah. Okay, so that's what we are using strain mostly for pattern recognition. But I will go through the different utilities of strain imaging. Okay, we are not here to make you strain experts. We just want you to appreciate where best to place strain in your clinical practice lah. Okay, but first big question is, when NS call you for an echo, what do they want? EF, good. Okay, very good. Okay. So far all hit. Okay, everybody also knows that they want EF. Okay, so EF is important. It's important to know EF because it's our center lah. We've been using EF for so long already, but there are some pitfalls to EF. And we'll discuss it in a bit. So first, EF, how do we calculate? Normally we calculate using biplane Simpson. You will read this in most of the reports. Okay, what is biplane Simpson? Basically, it's multiple discs being stacked up, and then we want to calculate the total volume of those discs. Why is it a disc? Why is it not a cylinder? Because your LV is not a cylinder. Your LV is like a bullet, right? And the tip, it will taper, right? So the cylinder, the disc will be smaller at the tip lah. Then we will calculate all the discs together, calculate the total volume in diastole and then in systole, and then we do the EF equation lah, to calculate EF. Now the good thing is everything's automated already, so you don't have to think so much, just draw only. So your art skill has to be good lah. Okay? Right. But there are some problems, some fallacies with EF. Number one is not everybody's LV is a bullet shape lah. Some are like a mushroom lah, some is like a broccoli lah. So the problem is that geometric change or distortion, right? EF calculations cannot take that into account. So you may over or underestimate. That's number one. Number two is things like LVH. So when you have very thickened LV wall, right, for example, and then this is diastole, and then this is systole, and then diastole, and then systole. What do you think the EF of that patient will be? Remember, EF is how much blood gets ejected out, right? Every time it contracts, right? So what do you think the EF will be? Poor, really? It'll be super good because it's so thick, right? The cavity inside your LV will be so small, right? And then by the time it contracts, it'll be obliterated completely, the cavity inside. So it's like falsely good. But your LV is so thick and it's so unhealthy. So how did that normal or supranormal EF value reflect that unhealthy LV? So that's why we have problems with EF lah, because it's not representative truly of systolic function. Now, we try to do 3D imaging lah, try to do different angles and all that. Maybe if you have different angles, maybe it's a bit more accurate. We know that 3D is not that accurate and not the easiest to do. It's very time consuming, you have to take many planes, and artifacts is the main issue. So if you have breathing problems, COPD lah, or you have arrhythmias, PVCs and all that, you really cannot take a good 3D picture because it's very dependent on your ECG. So even 3D as well is not very... it's not used practically lah, in clinical sense. Okay, so we have to think beyond volumes. We have to think beyond measuring the cavity. We have to really look into the LV wall itself to understand what systolic function is, and that's why we do strain. So what is strain? Strain basically is take any point in the LV, okay, and how much that point moves over time. The good thing is we are using a machine, so the machine can take many points, and then it just calculates all that movement at one go. Okay, the thing with LV movement is there's many things that contribute to LV movement, or there's many ways that LV moves. How does that LV move? Contraction. How? Kuchup like that, is it?
Yeah, contraction like that.
I think it's a kuchup like that.
Yeah.
But if you remember back in medical school, it's like a towel, and a towel that moves this way, but the other side moves the other way. And it's like opposite direction, so it's very complex. But there are three main movements that we've appreciated. One is longitudinal movement, LV movement like that. Two is radial movement. So radial movement is basically thicken, thinning like that of the LV wall. And then third is circumferential shortening, the twisting motion lah. Okay. Of these three, we tried to look at which one was the most accurate for systolic function, and we found out that longitudinal movement was the one that was best lah. There is some evidence to show radial and circumferential as well, but that is more for research. We've not used it in clinical practice. So that's why we are now we are stuck with longitudinal strain. So when you see in most things when they report or order, it's GLS, global longitudinal strain. So that is what we know about strain lah. So what do you need for strain? One, you need a machine that can do strain lah. Okay. But number 2, 3, 4 is you need an apical 4 chamber, an apical 2 chamber, and an apical 3 chamber. Okay, so that one we're going to teach you how to acquire lah. Okay, and a good apical 4, 2, and 3 chamber. Then the machine will automatically, semi-automated, calculate the GLS for you because it's many dots. You're not going to do it manually lah. Good thing is then after that it comes up with something like this, a bullseye plot. Okay, easiest thing to remember for you guys, bullseye plot. The redder it is, the healthier the heart. The pinker, whiter, bluer it is, the more unhealthy the heart. Okay. The good thing as well now is we can come up with values as well for GLS. That means the purata or the average of all these values, right? And we have normal values already for GLS. You used to have problems because different vendor, different normal values, but not anymore. Okay, it's all synchronized already. Okay, so some examples. 50-year-old woman referred to me for cardio-oncology assessment pre-chemo, doxorubicin because breast cancer, EF 55%. What do you think about the EF? Oh, but I measured already 55%. But doesn't feel right?
Yeah.
Yeah, so there are some regional wall motion abnormalities. So remember I said the geometric distortion and all that, EF is not very good lah for that, right? So it doesn't look that healthy. Okay, but so to validate your feeling that it's not healthy, right? That's where GLS comes in handy lah. So we did GLS, okay, and you can see there are areas of red, but definitely areas of pink and white as well. So this LV is not healthy. There is subclinical LV disease. And rightfully enough, we started this patient on beta blockers and ACE inhibitors prior to the chemotherapy, even though the EF is 55% for cardioprotection. And this is where GLS shines at the moment. We use it mainly for cardiotoxicity, chemotherapy, cardio-oncology. Okay, that's where most of the evidence is lah. Another case, this is not an ECG course, I know, but then it's still important. 14-year-old, 1-4, female, palpitations. Diagnosis? Oh, very smart. Oh, very fast. Okay, despite you sniffling. Okay, very good. Okay, Parkinson White. Yes. Okay, so next step.
Next step.
Yeah lah, next step we'll do what? Clinically. You, there's 3 people in a row already. The reason why there are not enough Holters in Malaysia, you know, I swear. Don't Holter lah, we already got the diagnosis already. What's your next step? Okay, so EP lah.
Yeah.
EP lah, right? So EP, correct. So we refer to electrophysiologist. So that was the plan actually, right? Then after that we dig story. She has a brother who's 21 years old who died from hypertrophic cardiomyopathy. So yeah lah, we have to do an echo lah, right? Just to make sure. Do you think it's hypertrophic?
Yes.
Okay, so these are papillary muscle, so it's just a bit thickening of papillary muscle, but it's not actually hypertrophic. Okay, the LV is actually quite healthy, like EF is 55% as well. Okay, so maybe she doesn't have the condition like her brother, right? This is a GLS. Ignore the one on the right, the left. So from the GLS, what do you think?
Not really good.
Yeah, so it tells you already not really good. Something is wrong. My measurement is okay, but then my GLS is still pink and white. So this patient is of a family of 8 siblings. Okay, they all have a condition called Danon disease. So Danon disease is an infiltrative cardiomyopathy that can cause both Parkinson White, but can also cause hypertrophic cardiomyopathy as well. She's lucky because we picked it up early before it manifested into hypertrophic cardiomyopathy, but she has subclinical disease already. So GLS was helpful here because yes, she might need the EP and all that, but ultimately she needs a heart transplant, and that's what we're working her up for at the moment. So we're referring her to IJN soon lah. Alright, so we're going to focus on LV mainly today, but there is utility for strain for LA and also RV, and that's something you guys need to know. So LA strain, much easier to do, much easier to understand. You have 3 values that will come out: reservoir, conduit, and contractile. Okay, reservoir is the one that's the most important, basically how much the LA can hold lah. Okay, and we've shown from data if your reservoir values is abnormal, you had a stroke, you have no AF, but your reservoir is abnormal, your risk of getting stroke and AF in the future is very, very high. So this might actually help to decide whether a patient should be screened a bit more harder, Holter a bit longer, something like that, to really look for their AF. Okay, so that's one function. We'll talk about the practicalities of LA strain later. basically, to get a good LA strain, you must have the biggest LA possible. And the current way you do an apical 4-chamber to look for the LA, right, is not enough to look for a big LA. Because remember, the LV and the LA are off axis. They are not like that. So if I want a nice LA, I have to make my LV ugly. Then only my LA will be big. We'll show you later. You have to be a bit more hands-on. Okay, that's fairly okay. So the other one is RV strain. RV strain is quite important actually, because unlike your LV, 80% of your RV function is longitudinal movement. So that's why strain, which is the longitudinal movement here, is very useful for function. Okay? Just like LA as well, you need to get good pictures for your RV. The current way we do apical 4-chamber isn't the best way actually, because you're going to either lose a bit of RV or the RV is going to be small. Remember, your RV doesn't have a shape that is the same all the time. Okay, unlike your LV. So you need to find the biggest RV possible. You need to open up the RV as big as possible. So we will show you how to do an RV focused apical 4-chamber view later. Okay, to open it up. RV strain, just like your GLS, they will come out with 6 values later. There's 3 on the left and 3 in the middle septal. What if I told you that you only need to worry about the 3 on the left? The middle septal ones, the 3 down, you actually have to ignore. Why? No idea, okay. So remember, the septal wall is shared by the LV and the RV. Okay, so if you want pure RV function, a lot of people believe that you should only use the free wall value. Okay, then we have one good example, this gentleman as well, reasons why you should ignore the LV. Okay, and we'll show you later.